Good morning. I would like to call to order the meeting of March 7th for the Pierce County Human Services Committee. Thank you for joining us. Sorry for the 5-minute delay. We were making sure that all the technology was going to work. So here's hoping we have solved all those issues. Could the clerk, the time is 9:36, and could the clerk please call the roll?
Yes, thank you. Councilmember Campbell.
Here.
Councilmember Mello.
Here.
Councilmember Krueger. Here. Councilmember Herrera.
Excused.
Councilmember Hitchen.
Here.
You have 4 members present.
Wonderful. 4 members present mean we have a quorum, so we can get to the business today. We're going to start first with approving our agenda. We only have 1 item on the agenda, but it's a topic we've been dealing with for a while. Any objections to or changes to the agenda? Hearing none, we will consider the agenda approved. We will go on to our minutes from February 21st, 2023. Does anyone have any corrections, additions, or changes to our agenda? There was one Scrivener's error where we got the title wrong for Mr. William Bridges, and that's going to be fixed, but the content did not change. Hearing no objections, we will consider the minutes for February 21st, 2023 approved. We were also joined by Councilmember Denson this morning. Thank you for being here. So with that, I'm going to turn this over to Ms. Merrick to kick off the bulk of our meeting this morning. And thank you to all of our guests for being here virtually. Thank you, Ms. Merrick.
Thank you. Good morning, Madam Chair, members of the committee. For the record, Lee Beth Merrick, committee staff. The item on the agenda, we're on item number 5. It is the Behavioral Health Workforce Report. Just for some brief background, there have been 2 recent studies done in the county looking at the behavioral health workforce. So the first study was directed through a budget proviso in the most recent biennial budget, where the council appropriated $85,000 from the behavioral health tax for the Human Services Department to procure a consultant to assess behavioral health and mental health provider capacity and determine workforce development and behavioral health system needs. The Human Services Department selected Advocates for Human Potential to conduct the assessment and develop the report. The second study was done by Workforce Central, where they convened a group of behavioral health practitioners from across the county to better understand the barriers that exist to entering and progressing in the behavioral health workforce. The Advocates for Human Potential's report pulls in the findings from the Workforce Central study. So joining us today from the Advocates for Human Potential to present their report is Susan Lang, Alan Fowler, John Starkle, and John Brumbach. We also have Katie Condit from Workforce Central and Richard Van Cleve from the Human Services Department joining us. They'll be available for any questions that pertain to their work. So with that, I think I'll hand it over to Susan to kick off their presentation.
Great, thanks so much, Lee Beth. We also have 2 other AHP colleagues that I'm going to introduce in a second as well. They are our business unit directors. So thank you so much, everyone, for having us today. Our AHP team has had the privilege of working with Pierce County Human Services for the last 6 months, and we've conducted a quantitative as well as a qualitative analysis of the behavioral health workforce. Today, we're really excited to share our high-level recommendations and action steps with you. One thing I wanted to call out right from the get-go is really just the level of engagement and the willingness for folks to think strategically. With all the stakeholders that we connected with in this study, we were really excited by their energy and their enthusiasm and their willingness to come to the table, some of them repeatedly with us. There are clearly challenges within the behavioral health workforce, not just in Pierce County, but nationally. But we really want to call out we found some incredibly positive things that are happening within Pierce County, and we lifted those up in the report. Next slide, please. So I'd like to take just a few minutes to introduce you all to our team today. So with us, we have Patrick Gauthier. Patrick is our business unit director and has a wealth of experience working with MCOs and is also our expert on funding and reimbursement structures. John Starkle did all the work on the labor market analysis and ran our data as well as the environmental scan. Alan Fowler was our writer on the project and has a background in workforce development. And John Brumbach, he is our local boots on the ground Washington native and has deep experience with HCAs and MCOs as well. And also joining us today is Rich Landis. Rich Landis is also a business unit director with us at AHP and comes with a lot of experience in behavioral health workforce development. So that is the team with you all today and the team that worked on this report. Next slide, please. So for our agenda today, we really want to dig in really on the recommendations and the action steps, but we're going to spend a little bit of time grounding us in the root causes of the behavioral health workforce challenges. So we're going to go through just, a few data sets to ground us, and then we will have plenty of time, I think, at the end for questions. And discussion. So if you want to hold those to the end, that would be great. Next slide, please. So here are just some of our high-level summaries. Next slide. So to get started, I just want to be clear about the language that we're using. So when we use the term behavioral health, we're talking about training and expertise in both mental health and substance use disorders. Where you see language in the report and in our presentation today that speaks to mental health and substance use disorders referenced, it means that they are independent of one another and not necessarily integrated under that umbrella. As you know, we understand that the behavioral health workforce has serious challenges right now, and so we really just want to lay the foundation. So a couple of quick stats. As of 2017, Pierce County had 59.6 counselors for every 100,000 people. This is actually above the US average of 33.9 per 100,000 people. However, Pierce County has a greater need. So the rate of serious mental illness in Pierce County is 24% higher than the state average. So even though the numbers look good at face value, not quite so robust when we look at the need. For this report, again, we want to talk about the root causes. So integrated care, for example, it remains the goal, but without appropriate levels of investment and funding, paired with adjustments in pay and reimbursement rates, integration will continue to offer mixed results in terms of both sustainable behavioral health workforce and health equity. And it has also created some new challenges for behavioral health organizations and the behavioral health workforce, and we'll talk about those in a minute. Behavioral health professionals have exited many community organizations for better pay and what's perceived to be less difficult work, such as smaller caseloads. And health systems and MCOs have been able to attract and integrate behavioral health professionals, while community behavioral health organizations have struggled to retain their incumbent workforce and also have struggled to recruit new workers as well. So without intentional, substantive, and sustainable funding, integrated care and health equity will remain an aspirational goal rather than an actionable one for right now. So I'm going to turn it over next, if you can go to the next slide, to my colleague, John Starkle, who's going to talk a little bit about some of the quantitative data. John?
Thank you, Susan. So in terms of getting a better understanding of where Pierce County is and where it will be in the future as it pertains to the behavioral health workforce, we went ahead and selected some of the most common careers in the field and went and used HRSA data to see how the supply and demand is going to change over the next decade. And as you can see, for a lot of these careers, the supply is actually going to go down. It's going to decrease. Psychiatrists will decrease by 70 and addiction counselors by 140. And then with the increase in demand that's expected in the next decade, you'll see that none of the fields that we selected will be keeping pace with demand. So supply, if it continues as predicted, is not going to meet the demand needed for the county. Next slide, please. And then, so one of the central issues we kind of looked at was wages, and we used Department of Labor estimates to get an understanding of how Pierce County compares to the rest of the country, and then kind of contextualize that using living wage data. So as you can see, Pierce County has significantly higher wages for most of the careers we looked at. However, as you can see, as it stands, with Pierce County having a higher cost of living than much of the US, most of the wages are not meeting the needs to raise a family, or in some cases to even live on your own, considering the county's higher than average cost of living. So that was one factor we looked at. Next slide, please. And then to sort of tie together what we found in the data, we enlisted the help of a wide array of stakeholders and conducted key informant interviews and listening sessions to get a better understanding of what this data looks like in the real world, and other problems that just couldn't be lifted up by the data. Susan already mentioned this before, but we had just a really engaged set of stakeholders, and it was very wonderful. Everyone was super engaged and was really trying their best to better the situation. So definitely Pierce County is in good hands in that way. So.
Next slide, please. Thanks. So from the key informant interviews and the stakeholder listening sessions, and you just saw the list from the slide that John talked through, we saw two major categories to really bucket our findings in. And so people and personnel was one and systems was the other. So I'm just going to lift up some of the themes that we uncovered from those listening sessions and the key informant interviews. So on people and personnel, what we heard was, work and behavioral health is relational, and there's a need for clear and intentional communication and expanded collaboration, and that's foundational. And whether that's in terms of public perception, career education, recruitment, and staffing, and employee well-being and retention. Careers in behavioral health are perceived as difficult with less pay, so successful career education and recruitment must flip the script to honor the importance of the work. Supervision, and here we're talking about both in terms of sufficient capacity for supervision and the efficacy of quality supervision, are real issues. Many supervisors find themselves unprepared and overwhelmed. Folks lifted that up. Well-being in the workplace is key to an organization's retention and recruitment strategies. Well-being comes from this sense of staff feeling heard and recognized and valued. There's a lot of fallout from the pandemic for sure, but mental health challenges and the demand of helping those with mental health and behavioral health diagnoses, effective onboarding, training, mentorship, and supervision are really, really important, more important than ever. And through our key informant interviews, stakeholders recognize the need for a multifaceted set of solutions that require coordinated implementation and strong communication. What we saw happening live in some of the stakeholder listening sessions was folks coordinating and talking about sharing caseloads or doing cross referrals live in those sessions. So that coordinated strategy and strong communication within the provider community we saw live and in action. In terms of systems, stakeholders must align around common goals, and collaboration is essential. Unified advocacy is needed to address education initiatives, credentialing, training, salaries, and compensation. Partnerships in a continuum of care model offer a stopgap until investment and funding can catch up. The county also recognizes the need for a robust pipeline strategy. So not only to replace folks who have exited the behavioral health workforce as a replacement strategy, but also to be able to meet increased demand, so that more folks coming into the system looking for services and support. So there's a need for building out the workforce even more. And then in the listening sessions, folks called out gaps in the education system. And there's really a need to support training as well as address the lack of clinical supervisors to support staff who are working on their licensure. Even with a strengthened pipeline strategy, there's a need to address the levels of pay for those in behavioral health in order for the pipeline to be sustainable. We know that disparity looms large, particularly between compensation in behavioral health and those in physical health care. And so, we've seen that through some of the lower reimbursement rates that are approved for Medicaid. And so what we heard from some of the providers was that, folks having really large caseloads in order to bolster the reimbursements, and that is contributing to burnout. And what's really important to note, again, is just the level of engagement with the stakeholders. Even though, these are tough times, the workforce is struggling in many cases. But we were struck by, and this will be a resounding theme throughout our presentation today, is that the bench is deep and folks are still optimistic within the provider community. And we uncovered some really innovative strategies that are already happening in Pierce County, and those you can find in the report. We called those out as well. Next slide. So now we're gonna move on to recommendations. And so next slide, please, Leva. So in the recommendations, I just want to acknowledge that these are recommendations that are more in the realm of state control, not necessarily in county control. However, these are areas where Pierce County can really advocate for change and take a leadership role. So we're going to dive into each of these individually. Next slide, please. So in this first one, this is the first recommendation is to have a policy level commitment to workforce development. So set adequacy standards focused on health equity. So within the Affordable Care Act, it requires payers to offer sufficient choice in providers, and when they cannot, they must offer out-of-network coverage. So Centers for Medicare and Medicaid offer some national standard recommendations, but Pierce County can go further and advocate for the creation of state-specific standards that include language and cultural requirements. So by compelling the MCOs under the Healthcare Authority to meet higher standards, the plans can be forced to develop a solution or allow for full out-of-network reimbursement. Support funding and staff. So staff leadership has the power in implementing workforce development strategies that providers don't necessarily have. Pierce County can advocate with the state to create a coalition of municipalities to provide technical assistance in allocating and spending opioid settlement funds that could support the workforce growth. And expand training and further support recruitment and retention efforts. Foster cross-agency collaboration. Partnership across state agencies could help coordinate the workforce development programs across sectors. I am based in Massachusetts, and in Massachusetts, there's a workforce skills cabinet, which is comprised of this, cabinet level secretaries in the state. So the Secretary of Labor and Workforce Development, the Secretary of Education, Secretary of Housing and Economic Development all come together to look at critical workforce challenges. And oftentimes will make policy level decisions and coordinate funding to really tackle some of those challenges. So there's an example from another state. Innovate workforce supports. So here to form a committee that can explore Medicaid treatment programs, participation vis-a-vis licensure. So the state could provide clinicians with college tuition supports or licensure support in exchange for clinicians agreeing to focus on a Medicaid population and substance use prevention and treatment programs. And so there's an opportunity there. And then lastly is data collection, bolstering the data sets and collecting that data and looking at it regularly and watching for trends and changes in the metrics is really, really important. Establishing a minimum data set could be really, really helpful to monitoring what's happening within the behavioral health workforce. I'm going to turn it over now. So next slide, please. I'm going to turn it over to John Brombach, who's going to walk through the other policy recommendations. John?
Thank you, Susan, and thank you, council members, for giving us the opportunity to share our work with you. So moving on to recommendation number 2, focusing on the coordination of systems of care, starting off with really reinforcing the integration of behavioral health care at the clinical level. Obviously, over the past several years, the state has worked on the financing integration of behavioral health and primary care and physical healthcare services. However, this has not resulted in the widespread clinical integration that one would hope and expect from those efforts. So we really believe there's an opportunity for the county to work with the state to help to enforce and require clinical integration of behavioral health and primary care and in primary care settings, really ensuring adequate access by expanding the number of care settings for behavioral health. Secondly, and along the same vein, really extending the SUD treatment capacity of traditional medical providers, specifically when it comes to MAT or medication-assisted therapy. And there are a number of federal tools and resources to help achieve this, and we hope that the state leverages these resources in order to achieve this recommendation. However, for the third bullet, clinical tools and care settings go a long way, but they're not quite enough. We really believe that there needs to be a culture, a change and shift that really drives reform in addition to the policy changes we're talking about. This can be done through diligent assessment and of cultural opportunities and barriers, training, education, and other resources targeting to elevate the opportunities that are found and addressing any of the gaps or barriers. And then moving forward to the digital divide, there really needs to be dedicated support for community organizations, less sophisticated providers to really fully leverage health information exchange, electronic health records, and other digital tools in order to help keep up with the state's various transformation goals and the counties. And then additionally, really looking to ensure that our mental health and the SUD providers are operating at the top of their license and really maximizing impact and efficiency of service. There really needs to be ongoing grant-funded or free to access, readily available training and technical assistance in order to maintain that level of expertise and ensure that our providers are doing everything they can to serve their population. Going again along to improving care access and care settings, as well as building the pipeline, implementing behavioral health services in school settings really works to both improve access to care while at the same time reducing stigma of accessing behavioral health services and really helping young people and others accessing those services improve, increase the possibility of them pursuing behavioral health as a career choice after school by being exposed to those services earlier on. And then lastly, for this recommendation, and really very importantly, standardizing screenings. Administrative burden is really obviously a common theme you hear from the provider community, and fragmented assessments create significant administrative burdens for providers, which takes time away from providing care and really contributes to burnout rates. So standardizing these processes can really help improve outcomes in these areas among a wide variety of providers. Next slide, please. Okay. So our third recommendation focuses on financing and payments transformation. And first of all, and Susan spoke a little bit to this, really enforcing mental health parity. The federal regulation, the state really needs to step up in enforcing it at the state level. Low inequitable reimbursement rates for Medicaid behavioral health services, especially, really is driving an exodus of providers away from publicly funded behavioral health programs. We really recommend that you work with the state to improve the state's regulations, improve enforcement of those regulations in order to balance out reimbursement and authorization standards for comparable primary care, physical health care services. Secondly, when we're talking about payment reform and value-based reimbursements and payments, any transition to these arrangements really needs to come with ample access to training and technical assistance to help providers make this transition. If done well, value-based payments can address many of the gaps that we're talking about today in terms of reimbursement rates and covering the cost of care. However, they need to have the support necessary to be set up for success in these initiatives, otherwise they'll be left behind. And then similarly, along the lines of payment reform, in managed care models, we can set up guaranteed minimum spending models or subcapitations. These provide agencies with revenue stability and the ability to fully capitalize on providing quality care, bringing up resources for higher compensation or employee retention efforts, and also significantly reduce administrative burdens of providers so they can continue to focus on providing care. Expanding loan forgiveness to offset educational expenses, that's fairly self-explanatory. There's more details in the report there for that piece, but moving on to SUD surcharges, we recommend looking into adding surcharges to alcohol, nicotine, pharmaceuticals that are prone to misuse to help address SUD rates gaps or other workforce durability initiatives. And then lastly, for this recommendation, really looking at following the national best practices that have been found for improving workforce retention, recruitment, retention, and durability. More details in the report, but essentially really focusing on areas of reimbursement, areas of administrative burden, and areas of points of access into the behavioral health workforce, improving the number of or kinds of provider types to help reinforce the behavioral health workforce. Next slide, please. And our final recommendation focuses on the creation of a behavioral health workforce center. This center should be focused around a common minimum data set so that recommendations, policies, actions around workforce development are driven by data and that they are evaluated based on a common set of metrics. Secondly, looking to build the county and regional capacity to inform and drive these workforce policy changes, leveraging best practices such as UW's collaborative care model in order to elevate these approaches and using that county infrastructure to help elevate those practices. And then lastly, the center needs to be a really best practice hub or a clearinghouse for effective models such as the Hope Sparks model, the Comprehensive Life Resources model, so that these aren't isolated approaches, but really system change efforts. Next slide, please. So these recommendations really demand deliberate and immediate action in order to really maximize their effectiveness. So my colleague Alan is going to speak to some of the tangible next steps we've identified in order to make these recommendations a reality. So Alan, I'll turn it over to you.
Thank you, John, and good morning, all. Next slide, please. So I'm going to start off with a graphic here that sort of represents the ideal model, where there's a strong philosophical financial foundation. I'm using my hands. If I don't use my hands, I can't talk. Strong foundational model. You've got 7 pillars there, and those are the 7 avenues for action, which don't actually operate distinctly, but really overlap and operate in continuum to sort of lead to that well-rounded, well-funded, well-staffed behavioral health system. Next slide, please. So I'm going to walk through the 7 action steps, those 7 pillars. I'm going to spend a little time on this slide giving you some background for all of those action steps. First of all, we see these just as the recommendations sort of sit at the state level. The action steps really sit at the local level. These are where the rubber's going to hit the road for the folks in the room here and also for other folks in the county. And to that end, you'll see here we have a little box that says who's involved, and that's in the report as well. At the end of each action step chart, there's a who's involved. And this is not exhaustive by any means, but it does give you a sense of who are the folks who ought to be at the table, who you might think about inviting to the table when you begin an initiative or think about taking some action. And also I'd lift up, actually what we've already accoladed the county for is the need for really strong communication, collaboration, and coordination. And sort of, frankly, you've got a head start on that. That is the culture we found in talking to you all. But that needs to continue, I think, as it enables you to coordinate more clearly. If someone's starting an initiative, other folks can either lean in by doing the same in their organization, lean in to help, and you can really build some momentum and some traction in that regard. And this first slide's a good example of where all of these bulleted points are in brief of what is spelled out in much greater detail within the report. So for retention and recruitment, you're going to see 2 pages of bulleted strategies and stuff. We have started shifting retention first. We recognize that if you can stop the churn and the turnover, you can be much more deliberate and targeted in how you are recruiting and what positions you need to recruit for. Next slide, please. So we're talking about extending the workforce capacity. And this is about sort of the current staff you have developing their skill sets. So it's not about adding more to their plate so much as ensuring they're working at the top of their license. This includes making sure your peer workforce is used well, that their lived experience relates to the work they do within your organizations. So if upskilling or cross-training or micro-credentialing will help your staff be more confident and less overwhelmed in their responsibilities, we want to be sure we make those opportunities to extend their capacity are available. Next slide, please. And this is one of those pillars, one of those action areas that really cuts across everything. So well-being, diversity, inclusion, equity are also retention and recruitment strategies. They're also about capacity strategies. It's about that work culture John was speaking to, that changing of the culture. You know, this is one of those key pieces. Even though we continue to isolate it, we are now changing more and more about really seeing it as inculcated through everything you're sort of doing. And what I'll lift up here is the importance of the supervisory level, that they are key to being initiating real culture change, being sure they're well-versed and comfortable and advocating for well-being, that they're providing space for that employee autonomy and voice, and that's often the place where they can begin to identify leadership across all levels of staffing. Next slide, please. So the next pillar or action area is to expand education and training. We are finding at AHP with some other projects, we are being asked to do more training across ancillary staff, those who might not be providing direct service, particularly around SUDs and mental health issues. Helping, again, it's that culture change, helping everyone in the building recognize SUD issues, to be able to understand the arc of recovery, what that means, to have a better sense of how, who they might refer to, what's the referral process, and what that warm handoff might look like, so that everyone in the building is attuned to the challenges of the clients walking in a way that allows them to be working all in unison, sort of rowing all in the same direction. The other bullet I'm going to lift up here is around providing training in business and business management. I come from a nonprofit background where often we're cash strapped and you're wearing a lot of hats, and people get promoted not beyond their capacity to manage or run the business, but beyond their training in terms of running the business and their management skills. So it's really being aware of where can you identify grants and funding and educational that are business-oriented aspects. It really helps with that work culture and being able to sustain a healthy staffing model across the organization when those at the top are able to fulfill their capacity based on their training. Next slide, please. So this is another action step, I think, that cuts across a number of things, creating these career pathways, very transparent career pathways where folks, particularly at the entry level, are coming in and have a sense of what is their future in the organization or within the field. Everyone starts at that entry level position, but in a couple of years, they're looking for what's next. And that may sometimes involve going back to school for another certification or degree, but it also can happen within an organization. And being able to map those out with salary ranges and pay scales, which I think is something we can talk about in terms of job postings as well, making sure you're being transparent on what the money is available. And this, again, sits with the supervisor, that they can be integral to those conversations, to the goal setting, advocating for either promotions or lateral moves that really reflect their employees' priorities. Next slide, please. And here again, another accolade to the county. We've been doing similar work in different states and different counties around behavioral health workforce development. And within Pierce County is the first time we have had a prevention programming really lifted up as a key component, as its own pillar. And it makes all kinds of sense, right? Because a robust set of prevention programs and initiatives is going to address overall community health and well-being. It's certainly going to reduce the number of folks needing acute care. And it's going to contribute to a long-term balance and sustainability to your workforce needs. And it opens up another avenue of work placements, right? A good preventative programming. This, of course, has to go hand in hand with addressing reimbursement rates for outpatient services. So again, there's often, if not always, a financial aspect to a lot of these action steps, but it's a good place to start. Thank you. Next slide, please. Excuse me. So this is the last pillar, and it gets back to that developing that pipeline. And this can be a light lift as easy as keeping a sort of annually updated contact list so that folks, as they look to reach out or check about job openings or internships or what are you doing, they've got the right person and the right email. It can be more robust, where you put together a working group that meets quarterly or biannually to come together and talk about what people are doing around pipeline development. And again, to speak to that coordination and that synergy that can happen. I'll lift up here how important it is, and I think John referenced this, is getting into high schools, particularly around those junior, senior years, when young adults are starting to look for what is their next step at graduation, and making sure that behavioral health is in the mix in terms of how they're thinking about a next step, providing job shadows, internships, ways of dipping their toe in the water to get some sense of would they be successful at that. So again, I'll go to my last slide. I want to make sure that these are very quick, very bulleted, a lot more explanation, a lot more detail in the report. You're going to find subsets to these bullets. You're going to find links to other resources, links to model programs, and that sort of thing. So my next slide, please. And this is the last slide. I'm not going to talk through. There's a lot of text on this slide. This is another sort of graphic that gives us a sort of a behavioral health workforce conceptual model. As you can see in the blues, a lot of both challenges, a lot of solutions from the top affecting personnel, from the bottom up affecting systems. So there's recognizing how multifaceted and complex this is. But I think if you look at the right-hand side, if you can sort of agree on wanting to improve quality of care, wanting to improve community well-being, wanting to move the dial on health equity, if you can agree to those with whoever's sitting around the table, that becomes the common framework from which you do the hard work and you push and you advocate and you make some change. The last thing I'll lift up is we have communication here as a single bullet, its own bullet. But I'd argue, as we've talked about before, that that's going to run throughout. The ability to really keep transparent with who's accountable, what's moving along, what hasn't moved along, who do I make a phone call to, who else should we have at the table, how do we articulate this, advocating to the state level. All those, that communication piece will be huge as you move forward with this. All right, that's my spiel for you all. I'm going to turn it back over to Susan, who I think will open up the floor a bit.
Great. Thank you, Alan. Next slide, please, Leabeth. So now we want to hear from you. We just threw a lot at you. I think you all have gotten the report if you haven't had a chance to dig in. So this was really intended to be high level. At the end of this slide deck, we also have additional resources that you can look at your leisure. But if we can go to the next slide, we really want to capture your thoughts. So when we start with sort of, it was a high-level presentation, high-level summary. So any surprises or thoughts or comments?
Thank you, Susan. I'm going to look to my colleagues to see what came to mind for them and then open it up for discussion and questions.
Great, thank you.
Committee Member Mello.
Thank you, Chair Hitchin. I guess my first comment is one of gratitude. I'm really grateful that the council prioritized this work. I think this is incredibly important work, and I'm glad we called for it, and I'm glad we have a good team, professional consulting team that is helping us think about this in a multifaceted way. So thank you for the good work, and I know you started off the presentation by thanking the many partners that you involved in our hardworking internal staff, but our external partners who are service providers. Also want to acknowledge that, so thank you. I don't know that there's surprises. I think you teased out a lot of good detail. I was waiting for this presentation to really read the report so that it would make sense. So this is good context. Was only able to skim the actual report, but now with this background, I think the report will make a lot more sense to me. So I'll be sure to do that. I guess the one question that I know you have some other prompts for our discussion this morning, so I'll reserve some further comments. But I wanted to also acknowledge I appreciate the thinking you've done to help us illustrate what are actions we can do at the systems or funding level in local government, as constrained as our resources are at the local level, or constrained as our capacity is at the local level compared to the state or federal level. You've broken out what we can and should do at the local level versus the state or federal level. One of my requests would be if you could make that even more explicit. I don't know if that's possible at this stage in your work, in your engagement with us, but if there's any way to organize the next steps for the report, these are the top tier actions for you to advocate for state government, or these are firmly in the state government bucket of things to do, and we can go advocate to our state partners. These are things firmly in your control in local government, or these are the things you need to do to specifically advocate to the MCOs, or you get the point. But just help us put it in this, the sphere of influence, who we need to be really focusing the action steps to. And I think my final question and comment at this point is, again, I greatly appreciate the qualitative analysis and outreach you did to our service providers that we really could not deliver the system without. I'm wondering what conversation you had with them or externally with people with lived experience accessing the behavioral health system. Was there anything done with people with actual lived experience?
Yeah, I can take that. So there were several folks who were in the listening sessions who were now in the provider network who had lived experience. And so they were represented in the conversations that we had. So yes.
Thank you. And was I threw a lot at you in my comments.
Yeah.
Is the other request doable with our engagement with you?
Our engagement is, this was under the existing scope of work, so we can go back and we'd be happy to have a next conversation with Richard Van Cleve and his team at Human Services, if that's helpful.
But when I add to that, Susan, though, I think as folks come at this, particularly the action steps, particularly and the bulleted points, where it starts to get into the weeds a bit about what can you do and what are some programs you might be able to do. What we're hoping is, even if we don't give overt direction at this point, they will find a bullet they can lean in on, no matter the size of the organization and the number of employees and the kind of work they do or the populations they serve. They should be able to go through, let's say, retention strategies and say, what are, looking at these 6 or 8 bullets, number 3 is something we need to work on. And here are some suggestions around how to start doing that. So hopefully, understanding the recommendations in general operate for state advocacy level and the action steps in general operate at the local level. I'm hoping people, as they say, well, where do I even begin, is to sort of say, of those 7 pillars, what's our weak link? Where do we need to lean in and go to the report? And I think they will find somewhere they can really get a foothold and get some traction, just as sort of a critical thinking methodology to approach the report.
I'm going to add to that, Alan, too. So when we've done similar kinds of studies with, in several places with states, we have helped to prioritize their recommendation. So, what we have said is those pillars are all priority. The urgency with which you take action might be different. And so we've helped with heat mapping those priorities. We didn't do that for Pierce County for a couple of reasons. One, you have an incredibly engaged set of stakeholders. So both, the providers, and the work that has been going on with Workforce Central, I will tell you, we haven't found in other places such an engaged workforce board. So, we felt like you have stakeholders that are already rolling up their sleeves. You have providers who are being innovative and creative in their approaches and their strategies. So, I think, there's already a lot of meat on the bones here.
Thank you. Thank you, Chair.
Yeah.
Richard, I saw you unmute when that question kind of came out. Do you have something to follow up or something to add?
Sure, yeah. Thank you, Councilmember and Hitchen and Councilmember Mello. I was going to say that's something I can help with too, having been involved in this. And I think when we look at the report and the recommendations, there's probably 3 categories. One is what should we advocate for? One is what can the council and others locally look at funding in the coming months and years? And then the third one is probably more around kind of what can we do to better coordinate and just kind of help the system be more coordinated around these. So I can work with AHP and I can get that to you too, as far as maybe like sussing that out a little more clearly. So.
Thank you. I think that would be helpful as I'm understanding the question. We have the ability as council members to network and advocate for policies to support our community at multiple levels, even with our neighbor jurisdictions, looking to other counties and lobbying together. And I think that is what we're looking for. How do we make sure that we are collectively expressing the need of our region at all levels of government and that we're speaking with one voice? So thank you. That would be incredibly helpful. I had one surprise, and then I want to make sure Katie, who's taking some time to be here, has a chance to chime in if she had anything. My surprise was on the data page where you said we had 59.6 counselors per 100,000, which was higher than the state average. Do school counselors count in that mix?
I believe it's from the licensure level, so I would believe so, but I can get back to you on that just to make sure. But yeah, I believe it's at the actual licensure level, because these are standard occupations from the Department of Labor at the federal level. I do know they have different categories for family counselors, so it might be the same case for the school counselors, but I was under the impression that they would be included.
Okay, I think when we look at that data, our school counselors are not often counseling. And so I want to make sure that would be important to us to really think about, because a lot of times they are also the scheduler, the parent coordinator, the fill-in-the-blank substitute teacher. And so they don't have enough time to really do the social and emotional work with youth. And so if we're counting them and saying, hey, we're good, it could be misleading. And so I just, understanding that would be really important. So that was my surprise. Katie, do you have anything that you wanted to chime in? And I know that your report is kind of embedded in here, but anything that you wanted to share or ahas that you had?
Sure, I'll be brief. Thank you, council members, for this opportunity. And I first will just say I applaud this report and the work that was done. It was incredibly comprehensive and engaging of the community across the county. You know, and I think there may be, in terms of your question, Councilmember Mello, low-hanging fruit or actionable steps at the county level, certainly around this idea of convening stakeholders and ensuring that there is space for that kind of cross-partnership alignment and learning of best practices. So we've pulled together a group that includes Comprehensive Life Resources, Hope Sparks, Multicare, a number of providers in the region for the last year that's been meeting pretty regularly to do just that. And I think there's opportunity to expand that to our education providers and other partners to make it a really robust space. So the foundation there for that is built, and that's a role that I think we can play in support of the vision of the county here. And then the other thing that stood out from us, you know, we pulled together practitioners in the field, those with lived experience, and that was our focus, just to say, what are you facing? And that's what you'll find in our report, and it aligns really greatly with what you've heard today. And I'll take it back to, in many instances, it's that earn and learn model that just doesn't exist as robustly in this field as it does in others. And I know we're partnering with the county with some ARPA funds to elevate and amplify earn and learn strategies across other industries. And it really, I mean, we have interns in the behavioral health field who are working and going to school interning and not getting paid for interning. I mean, in some cases, it's as simple or as complex as thinking about how to integrate true earn and learn models across this pathway. And that could look like loan forgiveness. It could look like stipends for internships. But fundamentally, there is a lot on the plates of the folks who are trying to get through these pathways and into the work. And so we have strategies we are working on at the local level through that lens as well. So in terms of recommendations, I think there's some low to medium hanging fruit here, and would love to continue partnering with the county on how we execute on what's suggested in this report. So thank you for prioritizing it.
Thank you. That was Katie Condit from Workforce Central, just for the record, and appreciate you taking some time this morning. I just want to make sure you had a chance to speak in case you had to chime off, I think, at 11, and wasn't sure how long we were going to go. So Councilmember Denson, you had a question or a surprise?
Yes, thank you, Chair Hitchin. Both, actually. At first, I wanted to recognize I really liked Katie's idea about stipends for internships. That's becoming more and more common in all sorts of fields, recognizing that not everyone can afford to do something for free because they need to make money, whether they're a teenager or a young adult or any age, actually. So one question I had, and it's in regards to state law, so I'm not sure who would have the answer, if anybody, but if somebody moves from out of state and they're credentialed as a behavioral health professional, does that transfer easily in Washington State so they can go right to work here? Anybody know? Something we can look into if you don't.
Yeah, well, I'm sure most people could answer this on this panel, but no, the answer is no, it doesn't. It's been a kind of a legislative priority on and off with the Department of Health to kind of work on that issue. Many other states, it's much easier to transfer in or even work from out of state and be, duly licensed in multiple states. But Washington State is kind of medium difficult. It's not the worst. It's not California, which I think is one of the worst, but no, it's not easy. You pretty much have to reapply and kind of prove your hours and, go through that whole process.
All right, well, maybe that's something that we can think of. And I did really appreciate some of the ideas of things that perhaps we can talk about adding to our legislative agenda for the state legislature next year, especially about the MCOs and expanding options of services. One other idea that seemed very basic. I don't even know, I never know where to look when people are on Zoom. Seemed basic, but I really appreciated it, is the idea of inviting past employees back, particularly with what these folks have gone through over the last couple years. We have seen in every field a lot of folks leaving these especially high stress areas, and reminding them maybe of changes that we've made to support them more. They've maybe had a chance to go try a different career, but they're trained, they're experienced, and reaching out and saying, hey, we'd love to have you back, and here's some different options of how work might look different for you. I mean, that to me is some low-hanging fruit of getting really valuable people back into the system. So I think definitely something for us to think about. Thank you.
Thank you for those thoughts. And I think my only addition would be, I know Representative Levitt continues to champion how do we get partners and spouses of military folks that come into the community. So that's a pipeline that we continue to work on because we know they might be only here for a short amount of time. So they're not going to invest. So they sit with a professional credential and don't help or support or access. And they are licensed and ready to take work, but they can only be for 2 years. They're not going to go through our system, so then they just sit, and it's a wasted opportunity. So she continues to work on that. The whole system's a little complicated, but that's one that really gets us, because we have some really highly skilled, trained people who sit and cannot provide a much-needed support. Committee Member Krueger.
Thank you, Chair, and thank you for an extensive report. That's a lot of work you put in. I went through the report last night. I do have some questions, and first, I'm wondering if perhaps you can define how do you define health, and how is the right behavior defined? So you're looking to get from this behavior to that behavior. So what's the behavior we're trying to change to get to? How do you define the appropriate behavior? Does that make sense?
Committee Member, I'm not sure that's a question that this report really kind of, because they aren't providing the health, they're talking about the workforce behind it as opposed to.
Correct, but I looked at it as, we're looking at behavior health, and, how can we help with the person who has issues? We're going into a system that is addressing behavioral health changes, because I noticed a lot of the theme, we have shared goals, equity, there's cultural change. And I'm also wondering on the cultural changes, we're looking at changing from what culture to what culture, because I don't see how that is defined in the report.
So when we speak to cultural change, let me tackle that one first. And I because I don't have a behavioral health background, I have a workforce development background, so I want to be very careful about how I talk about health and behaviors and such. When we talk about culture change, and I think when we think about workforce development wise, it's about that level of burnout. It's about this discussion really about inviting back employees who have left the system, that what can you do in the workplace culture that supports people in such a way that when stress, which is inevitable in the healthcare system, and I think within behavioral health in particular, is there, when you have pay disparities and some challenges around compensation, so that's another level of pressure or anxiety for folks. What are you doing in other ways that provide wraparound support so that people show up every day and happy to row in the same direction still? And I think about teams I was on who worked through the pandemic. What kept us together was somehow among that teamwork that we had was strong enough to counteract all those other negative pressures on us. So that's the workplace culture we're talking about. And it's not trying to suggest that any particular organization's culture is lacking. It's how to find out, identify, like a needs assessment, what's going well, and where are there areas for improvement, and how do we focus on those areas of improvement so that we're firing on all cylinders more consistently. And so that will slow your retention issue and allow for more targeted hiring issues. And the one way I'll touch on the behavioral health piece is when we think about employee well-being or employee engagement, that's a health issue. And so that's as far as I want to go. I'll talk about in terms of employees, but I'm reluctant to talk about in terms of populations because that's not my area.
And in the report, I noticed there was the mention of hip hop therapy and then Project Echo models. Can someone describe those?
Those are models that are being used within several of the providers. So hip hop therapy is really a prevention strategy to get young people at the middle school level engaged in conversations and working with counselors in a low stakes kind of way. So it's a way to engage young people in talking about mental health issues through hip hop.
Okay, and I guess this is.
And then the ECHO model. Hi, this is Rich. The ECHO model is essentially doing it's doing a virtual case studies. So you do a clinical case and you present the case, virtually, and then there's a discussion that happens that's moderated by SMEs around, the particular what are the course of actions and how you would address the particular case, in a clinical setting. So that's what the ECHO model is. It's another model of learning that has been highly effective, particularly for the healthcare field, but more and more being used in the behavioral health field.
And then it was electronic page 69, there was mention of covering toddlers. Can that be teased out a bit?
So that's one of the integrated care models within one of the providers in Pierce County. So they are, they have an integrated care model where they're working with pediatricians to lift up and so to do immediate on-site coordination around behavioral health or mental health issues that might be presenting themselves that are identified by pediatricians. So it's a quick way in for an intervention in an integrated care model. So all the things that you were referencing are evidence-based practices that we discovered in working with the providers in Pierce County. At the beginning, we talked about there's already some really innovative strategies that are happening. And so that was, all of these models that you just referenced is calling out what some of those evidence-based and innovative models are. So they're already happening within the county.
And one more, Chair. Was there any indication how Pierce County surpassed the state in behavioral health issues? Is that one? It was said that the SMI is 24% higher than the state average for Pierce County.
Yeah. Sorry, go ahead.
No, go ahead.
We found that Pierce County has significantly higher needs kind of across the board in terms of behavioral health. And one of the main reasons we kind of found that to be the case was obviously the large military presence presents a lot of increased needs. But yeah, we found significantly higher needs.
Okay.
Yeah, this is Rich.
The state hospital being present also would contribute to that.
Right. Yeah, exactly. I think there are very long-term reasons why Pierce County has higher acuity level. So some of that has to do with a higher percentage of Medicaid population, having a state hospital nearby, lots of group homes in our county, much more than most other counties. So you have this kind of concentration that brings that higher. I think the other, just to address the earlier question around health, there's a couple of ways to define health, Councilmember Gruber, and I think one is kind of traditionally a lack of symptoms or a lack of disease. That's so obviously trying to treat mental health issues. The other kind of more modern definition involves wellness, and that's some of the programs that you were mentioning earlier. So wellness being kind of this concept of having a fulfilling life, positive experience, strong family connections, and so on. So I think when we talk about health, it's really both of those.
Thank you for that. Thank you, Chair, and thank you for your work on this. I need to reread it again too. Lots there. Thank you.
I do as well. You had a couple other prompts on your last slide, so I'm not seeing anyone else indicating a desire to speak at this point. So is there additional information that you wanted to go through, or?
No, we just thought to generate some conversation, you know, as we referenced, we didn't prioritize the action steps or the recommendations, but thought if you were interested in engaging in that conversation, I'm curious to understand how you might prioritize those recommendations or the action steps.
I think on our end, and that brought up two lights as soon as I said that I didn't have.
Yeah.
So good job, everybody. But the idea around just, we need people to provide the services. And I think that we need to get really creative. I've heard this in every corner of our county, whether you're talking about our homeless service providers, our schools, our jails, but just in community where people are calling and saying, I cannot get my teenage child the services they need right now, and this is a crisis. And with what we're seeing, I need people to be willing to come into this job field, this career field, and you've got some creative pathways on here, so I intend to do a little bit more digging on some of them as to what they are and how they're possible, and possible funding pathways that we might have in partnership with our learning institutions, because we have several options within our county, which is one of the phenomenal things that we have. We have a full-fledged university in downtown Tacoma, but we also have private university in unincorporated Pierce County, and we have our wonderful tech and trade and community colleges. So we have opportunity. We just need to figure out how to support them and then make sure that we are casting a wide net, that we don't only do one thing. We need to do all the things. So I'm going to go to Committee Member Krueger.
Thank you, Chair. I don't know if you can elaborate on this, but in the report you had mentioned about dollars that were left on the table for, I believe it was miscoding, like 10 to 20%, and then 5% of the revenue was not being collected on the copay. That seems like an awfully lot. That, you know, how did you find that, or is there any comments on that, on people correcting that, or what that amounted to in loss?
I think that would require a much closer study, a much closer look at the data. I hope that those comments were made in a generalized way. That's the way they're intended, that it is not uncommon for both those things to be true. Many behavioral health providers struggle with coding, and that is the procedure codes and all of the other kinds of codes that are necessary for electronic billing. And particularly when claims are denied for administrative reasons like that, like coding, it's very difficult. They don't have the manpower to then correct those codes and resubmit them. And that's a generalized statement. The other, owing to the rate at which typically managed care companies will deny on the basis of medical necessity, is another phenomenon that is more present with substance use disorders treatment in particular. They tend to get denied for clinical reasons more often. And then on the copay side, again, a generalization that many of our nonprofit providers, if and when there's a $5 or $10 copay, struggle to collect the cash copay at the time of treatment service. It's a difficult thing to do when you're treating the indigent. Very often, people who've been released recently from incarceration, or people who are perhaps still very unstable in their housing, living well below poverty thresholds, to collect a cash copay. So to give you county-specific data would require a pretty in-depth analysis. But those are pretty general statements made about just about every behavioral health provider around the country.
Thank you. It just seemed that I can't help but believe that probably is the same across the spectrum of healthcare in any facet of that. And I just found that intriguing. There's a lot. So thank you very much. Thank you, Chair.
Thank you for those questions. Committee Member Mello.
Thank you, Chair Hitchin. I would prioritize next steps there's a lot here. So I would just note that I think the three, this is high level, but the three key next steps from my vantage point in listening to providers for a number of years now help me understand the system. I think our top priority needs to be around advocating for increase in subsidies so that we can get some better parity in pay, right? The availability of providers all comes down to competitiveness in the workforce. It comes down to compensation, largely. And of course, there's issues around culture and et cetera, but it really does, if we can do one thing, it's compensation. And we need the healthcare authority and other decision makers, Medicaid reimbursements, and the rest of the system to be much more competitive so we can recruit and retain the workforce. There's other good strategies I would put in that same bucket around education stipends, education reimbursements that help with retaining and recruiting that workforce. And I would also put in that bucket of work which is related, which is the work that we're doing with the Washington State Association of Counties around network adequacy, behavioral health network adequacy. So that would be those are the premier strategies that I think we need to go all in on to really get at recruitment and retention of the workforce. There's other systems work that is identified in the report that's really, really helpful. The second thing I would note is the list of next steps that Mr. Van Cleve noted, I think are very well summarized. And I think the council and this committee needs to figure out how to support Mr. Van Cleve and his team and the follow-up and monitoring and implementation of the findings in this report. We can't just receive this report today and not look at it again or not follow it for another few years. We got to figure out how to monitor and support the implementation of the findings. The third and final thing that I can think of at this moment is, we're putting out a notice of funding availability for our behavioral health dollars, our local behavioral health dollars, and I'm glad we are, and I'm not suggesting we slow that down at all. What I am suggesting, though, is we do have those local dollars where if through this report, through continued work with our partners and professional advice, if we want to take some dollars off the top of the behavioral health funds, like we do already for the therapeutic courts, we take some costs off the top where the council said these things must happen and are really important, like our diversion and therapeutic court programs. If there were a couple of other really important systems things that this report is calling for, that the council wants to take off the top before the Behavioral Health Advisory Group goes and helps us prioritize funding for all of the available resources, I think it behooves us to do that, to reserve some dollars for implementation of some of the systems work, because without the workforce, we can't tackle this really critical system. So this is so important to figure out. So I would offer that as a third point is before we spend all of the behavioral health dollars for the next biennium, we think, are there some critical things that we should be doing off the top to get at these workforce challenges? Thank you, Madam Chair.
Thank you for those thoughts. And I had similar ideas, slightly different twist, but the idea of looking at, is there a way to make sure part of the RFP included, we want to do a workforce development aspect of it. So it's still going through the same process, but maybe creating a bucket of money that we would like to devote to expanding workforce every time. Mr. Van Cleve, would you like to chime in on that? Maybe you already did it for us.
Yeah, so there was kind of two options we were looking at, and so as you may know, the RFP, behavioral tax RFP, is going to be released on the 13th, so next Monday. So we have a couple options, so we still have time to change the wording. So what we have in there now is basically we added behavioral health workforce activities or options as a new priority in our priority list in the RFP, and then we have a link pointing to this report and kind of pointing like, okay, we need people to work on this, propose your ideas. So so that's the way it sits right now. We could we could do like what Councilmember Mello mentioned and say, okay, we'll take that out and then just you guys decide how much money you want to reserve for this, and we do a different kind of approach. So so I think both are doable. It's just we would just need to know. That's all.
Thank you for chiming in. Councilmember Mello.
Thank you. I might offer both. I think it would be interesting to put it out in the competitive process, see who responds with what ideas. I continue to submit that the council reserves the ability to, if we're not getting the kinds of responses, but there's work for the county staff to do, Mr. Van Cleve, your division, to do at the systems level that we want to reserve some dollars for, or directly to Workforce Central because of their key role. We don't want them to compete for some reason. I'm brainstorming here, right? Maybe there's some data collection needs. The report calls out the data collections needs or some systems work that we need to be responsible for. Then we carve that out the top. So maybe a little bit of both. It would be interesting to see what our private partners come back with to respond here, and we might, and I think the council will always reserve the ability to be flexible and invest in the things that we know are going to move the dial the most. Thank you.
Thank you for those thoughts. I'm going to ask this question, see if lights come up. So does anyone else on the dais have additional questions or thoughts they wanted to? Councilmember Denson.
I just had a quick question regarding what Mr. Van Cleve mentioned with this behavioral health RFP. I think you mentioned that you were notating a priority for workforce projects. So I completely agree with Council Chair Mello about the way to proceed forward. I just don't want entities that are providing direct service to feel like they're not going to be as competitive, and I don't know how you're allocating points. So could you just explain that a little bit more? Because I think we still want both.
Yeah, no, that's a great question. So we have a number of priorities. I would say, again, off the top of my head, I think it's 6 priorities, including, outpatient services, services for justice involved. And, so we have 6 categories, housing. And what we did this year was we added a couple of new categories. And one of them is behavioral health workforce. So it's not that we're saying this one is above the others. It's kind of in a list of kind of equal priorities. And we ask for agencies to apply to one of those categories.
Perfect. I feel much better. Thank you.
So, Mr. Van Cleve, it sounds like we're going to have a couple follow-up conversations about this in the near future. And I know that this continues to be a high priority as we look at our workforce and also the needs in our county, thinking about our substance use disorder work that we have some intentional planning and work going on around countywide, and just what we're hearing out in our community. So, to the advocates of human potential, thank you. This is a phenomenal report. There's a great deal of detail in here that'll take a couple reads to really dive into, but appreciate the overview you gave us today, the detail in here, and the work. It's good to hear that you had a good experience working with our systems here. I know that we have a robust group of individuals and organizations that meet pretty regularly, and a lot of times that can kind of go sideways because it's so frustrating, and I feel like they have more hope because we are having these really detailed, intentional conversations around how do we do better, and I think it's very helpful to keep them engaged and willing to work with us as partners. So just truly appreciate this work.
Thank you for the opportunity.
Yes, thank you. I'm not seeing any more lights, so I'm going to turn this back over to Ms. Merrick and see if we have any other business before the committee today?
Thank you, Chair Hitchin. No other business. I just will remind you that your next meeting is on March 21st, where you'll receive an update from the Immigrant and Refugee Commission on their work, as well as an update from the Human Services Department about the county's work on Ukrainian refugee assistance.
Perfect. Sounds like a wonderful meeting. With that, we are adjourned. Have a wonderful afternoon, everybody.